You're listening to the Physio Matters podcast in association with Choose Health, and this is session 5. Welcome back to the Physio Matters podcast, and another huge thanks to all those spreading the word and engaging with us, especially on social media, as your feedback is truly valuable. Session 5 features part 2 of my interview with Mike Stewart, and it comes off the back of Mike's social media charm offensive, and I shall direct you to some brilliant resources that Mike's made available for free at the end of the show. Hang around after the interview for the up-and-coming No Pain course and lecture dates, including a special No Pain Choose Health collaboration, which is discounted for podcast listeners. But before we get started, I think it's appropriate for us to make a dedication. One of the founding fathers of modern pain science and most eminent thinkers on the topic, especially here in the UK, was Louis Gifford. My interview with Mike was recorded prior to Louis sadly passing away earlier this year, and almost inevitably when discussing pain and communication, Louis's name came up in our interview. Therefore, Mike and I would like to dedicate this podcast to Louis and thank him once again for his huge influence on our careers. And with thanks for his part in the content, let's get back to the interview. So understanding neurobiology and the higher centres and how they operate is really useful as a clinician to understand, but is that essential that we put that across to patients, and how do we do that best?
Yes, I think it is. I think it's important that us as clinicians have an understanding of the complexities of the nervous system. We must do that, and the evidence points us in that direction. But the question always comes back to, how do we make this meaningful to patients? And in a recent book by Professor Elaine Fox, from Oxford University, in her book Sunny Brain, Rainy Brain, she makes a very good point. And if we think about the complexities of the neurobiology that exists between the amygdala and the cortex, amygdala, fear, apprehension particularly, cortex, conscious realm of how we respond to stimulus, and if we think about the connections that exist between those two brain areas, the amygdala rules over the cortex. If we think of how many connections that exist between or going from the amygdala to the cortex, it far outnumbers those coming back from the cortex to the amygdala. And I think we can make sense to patients, particularly with this, through, again, a metaphor of an unfair water fight. We imagine that if we had a team of 10 people with water pistols and you're the amygdala, the cortex would be a team of 2 or 3 individuals. So no matter how much the cortex is screaming at the amygdala saying, don't worry, this is fine, it's all okay, I know all you're doing is bending down to go and get the weed out of the ground, the amygdala is ruling the roost. It's constantly soaking the cortex. And this is what we often see, and we have to explain how fear is very normal and how it's an unfair fight that's existing neurologically. So I think there are ways and means that we can explain and express complex neurobiological mechanisms in a way that works for patients.
Okay, and so there's a lot of research out there in terms of anticipation and apprehension and how that influences both fear and therefore movement. So what's our best interpretation of that and how to apply it?
Well, I think Lou and colleagues in 2007 uses FODA for measuring perceived harmfulness, and FODA being a photograph series of daily activities. And I sometimes think, as physios under a biomedical model, I was always taught the visual analog scale of the 0 to 10. But of course, one of the problems we come into there is we constantly get patients to attend to how their pain is. How's your pain? How's your pain? What's your pain like now? I recall a patient who was 9 years old, and she'd had pain for the last 3 years. And when we drilled down into what was going on, the mum's first question to the patient every morning was 0 to 10, how's your pain? What is it today? And of course, we'd fired and wired in a pain behaviour. But what Lou et al. Do by using FODA is flip that on its head and shift the focus towards function. Let's not mention pain. Let's talk about function. So if we use a score of 0 to 5, any functional activity, we look at the photographs, it might be putting the washing out or driving the car. 0 is an absolute doddle. You could do that all day long. 5 is no way, not on a month of Sundays. You're never going to get me to do that. That's way too tricky. We ask patients to try and figure out where their starting point is. Starting points aren't 4 or 5 for obvious reasons. That's a bit like being thrown in at the deep end and being flooded. Equally, the starting point isn't 0. Things shouldn't be an absolute doddle. So we're looking for a little bit of challenge within what's comfortable, or as we say, to it, not through it.
And what's your best starting point when it comes to applying that in clinical practice with patients of all abilities?
Well, I think, again, you have to relate it to what's meaningful to them. If they're a plumber and they've not been able to work for the last 6 weeks because they can't bend down to the U-bend, I need to say, well, why is it that you can't do that? Show me how you would do it. And of course, if they bend with their knees and get down on all fours and don't utilize their back muscles, but they have an adapted movement pattern, then the idea of FODA enables me to explore their thoughts or their beliefs about why they don't bend. What is it? What's going to happen? What's the worst case scenario? So it starts to come back to the idea that maladaptive cognitions lead to maladaptive behaviours, and I can make that link with them in a very physical way. Rather than just talking to them about it, I can do it in a physical sense that makes sense to them in a meaningful way.
And if they then think, well, I don't do it like that because it hurts and my discs are going to pop out like Jam Donuts bulging jam, you have to bring it back a bit, don't you?
You do, very much so, yeah, and that gives you, it opens an avenue of discussion. And without that, I sometimes have colleagues who say, how did you find that out? How did you get that information from the patient? And I always think, well, if you don't go down the path of that discussion, you're not going to find those things out. But I think also the other thing that asking them the 0 to 5, how easy, how hard is this? If I use flexion, say lumbar flexion, you can get patients who can only flex to 20-30% of what would be considered to be normal, and they can't go any further. And when you ask them why they can't, they'll say, well, it hurts, or it stiffens up, or I can't do it, or I'm scared of doing it. Some might be honest. So if we then trick their nervous system by getting them into a position that does the same thing, but something that they don't recognize, for example, on all fours with their bum on their heels and sliding their hands forwards, you often get to see that the patient can flex much, much better than they think they can. So again, I come back to that question to the patient, what's that about? Why can't you flex in standing, but you can in another position? And I've heard it wrongly explained as masquerading, or it's they're pretending and they're trying to pull the wool over your eyes, and that's the wrong way to look at it. I think the way we should think about it is, if you were scared of snakes, Jack, it would be very frightening if I threw a snake straight at you. If I dressed that snake up as a pillow, so your nervous system, your threat mechanism, couldn't recognize that snake, but saw it as a nice comfy pillow, it would feel fine. It wouldn't feel threatened. It would enable your muscles to do the job they were designed to do.
Okay, and so you set your patients a few basic tasks to work out how to pitch their rehabilitation at this stage.
Yeah, very much so. I think I always, again, use a metaphor of climbing a mountain. Where does the mountaineer start? Well, they start at base camp. You have to first of all discover where base camp is. And often in my caseload, I see lots of patients who've attempted physical rehabilitation not successfully in the past. And when you ask them, it's often that they've started the whole mission at 6,000 feet in the air, and they've not acclimatized first. And I think a common problem that I hear about in practice is, for example, some clinicians might think, well, hydrotherapy is an easy starting point. And of course, your belief as a clinician might be that that's the case. What does the patient think? What does the brain think of hydrotherapy? Well, it's hard. It's a challenge. Is it too much of a challenge? Sometimes. That's why some patients come back to us and say, well, I tried hydrotherapy. That's the first gear that you had for me, but I stalled the engine. What now? You have to Socratically collaborate to try and find where and what is your base camp on the mountain.
And what are your top tricks, shall we say, for tricking the nervous system into getting into positions? Because that often results in a really good buy-in. If you think you change someone's lumbar flexion strategy, do more of a waiter's bow, a more motor control or hip dominant strategy, that can often get a really valuable buy-in. What are your top tips?
Well, I think the first thing to do is don't labour the point. Don't make out that this is a psychological component here, or if the patient takes you down that avenue, then bring it back to neurology, to the wires. This is the wiring. This is the way we do things. I sometimes explain to patients about fasciculation when we see, eyelids that just randomly start flickering away, and that butterfly eyelid. Are you in control of that? Well, no, you're not. You're not in control of the way you bend. It's a bad habit. And that's another way. Another tip of mine is I would always get patients to think of habitual behaviours. Some are bad, some are good. Again, we can get them to Socratically think about, is the way you're bending here a good thing? If I took a population of 1,000 people between 18 and 25 and they don't have any pain, and I asked them to imagine that their spine was made of glass and that they should move very cautiously, are all of those people going to be fit and healthy in 6 months' time? So get them to think about how we as mammals are designed to move. I think another example of how we can use this type of concept with patients is we've all seen that wide spectrum of patients, whether it's the 2-week history of shoulder impingement type pattern, or whether it's somebody who's had shoulder pain for 20 years. This person stands in front of you, and when you ask them how far they can flex their shoulder, they go to 60 degrees. And then stop. Why do they stop? They stop because of a mixture of things. Again, a biopsychosocial model might interpret that in one way. If we then try and trick their nervous system into doing it another way, I often warn patients and say, be prepared, I'm going to ask you to think in some outlandish ways maybe. I always pre-warn them. But I think if I get the patient and me to pretend that we're Victorian gentlemen coming out of church on a Sunday morning, and we bow our heads with our bowler hats on top, and we stand from a bent position with our hand on top of our head on top of the bowler hat, and we say good morning by tipping the hat and lifting our arm in the air, I get patients to repeat this with me in front of me, with me mirroring them, and where they end up with their shoulder is right in the air with the hat up in the air, or the imaginary hat. And I get them to stop when their shoulder's now at 160
when
degrees.
In lumbar flexion?
Yeah, or when in standing, when in extension. Okay. Yeah, so the purpose here is for me to get them to see that if I ask them to flex their shoulder, they can't do it. If I get them to do it another way by, some might say it's a distraction technique, it's a tricking mechanism. If I get them to think about it as the Victorian gentleman who's tipping the hat, then they can do it.
So a patient can't squat, but they can do a decent sit to stand?
Yeah, very much so, Jack. I think what we're really highlighting here is this mismatch that exists between a person's functional ability and their apprehension avoidance. And that's something which we really need to address in practice.
Okay, so someone that's apprehensive, that's something that has been researched to an nth degree in the last few years. How can we use that research to teach other clinicians and also our patients?
Yeah, I think there's a lot of ways, really. I mean, some of the research, again, uses fMRI studies. Gondo and his colleagues 2 years ago now, or last year, actually, 2012, looked at an fMRI study, looks at pain modulation by anticipatory anxiety. So they used, I don't know who puts themselves forward for these studies, but people who would experience, whilst under fMRI conditions, a orange light and get a warm stimulus from a probe on the end of their finger versus a red light, which is a burning, horrible, painful stimulus. And of course, most people would get an amplification of hippocampus and amygdala when you receive the hot stimulus. But of course, when they mix things around without the participants' knowledge and started giving them the burn on the orange light, the same thing happens. So that we know that LTP takes place. The areas of neural connections potentiate. They start to sharpen the signal based on previous experience. And that's really what apprehension and expectation's about. If you expect it to hurt, it will hurt.
And you can't avoid that. This is a subconscious thing initially, but with training, you can decrease that.
Yeah. I often use a quote by William Shakespeare with patients and with clinicians, which is Shakespeare once said, "Expectation is the root of all heartache," and he was really onto something there. And the way that I try and get patients and clinicians to see how apprehension and expectation work, how they play a part, is through an experiential learning experiment that we use with a balloon and pin, where a group of people will stand with their eyes closed whilst I blow a balloon up as tight as it can go with a very large, I get the largest pin that I can find, and I warn them that whilst they're standing there with their eyes closed and I walk around them, I'm going to explode the balloon, I'm going to make a loud bang, and I want them to think about how their body reacts when I walk around them. And of course, as I approach them, we see lots of tension and lots of apprehension and, expectation. And of course, I don't explode the balloon. But we can see how this works. And one of my patients, when I did this with her in a group setting, she said, what you've just done there has got a very, very brief insight into how I live my life. So I often get across to clinicians that you might be sitting in your practice and feeling very comfortable, having had a nice night's rest and everything's going well, and you're heading out to the cinema that evening. That person who sat in front of you as a new patient or as a follow-up is that person who's constantly thinking the balloon's going to go off in their ear. They're sensitive, they're apprehensive.
They're on edge.
Very much so, yeah.
Okay. Lovely. And that then, all of these strategies, so we get to the point where we need to address and alleviate these concerns through tips and tricks and explanation. But we are, what I gather, is getting them into a position where we can train and condition this individual, put our physiotherapy hat back on, not that we ever took it off, but more of we start to go back towards a conditioning model.
Yeah, very much so. And I think your previous podcast with Lee Harrington makes this point very well. We have to get them to start where they're comfortable. And again, in my metaphoric language, I often use the idea that boats are most safe when they're in port. But that's not really what they're designed for. Boats that sit in port all day rust up. It's not a good place for them to be. They're designed to be out on the ocean exploring things. And this, if we think about how humans react to pain conditions, a lot of us have a degree of social withdrawal, just like the cat that hides under the table when it needs the vet. So we have to see that it's a normal animal response. But yeah, you're right. We have to start then thinking more about the physical aspect of graded exposure and functional rehabilitation within their confidence. But also, no system adapts without a degree of challenge. So we have to challenge their nervous system, challenge their musculoskeletal system, but to a point that they're in charge. My job is to challenge them. Their job is to tell me where that challenge, where the border between too much and too little lies.
Okay. What are your best examples then of how you would use graded exposure?
Well, I think once again, I think it has to be collaborative with the patient. You have to link it to what makes sense to them and what they're struggling with. So if they are somebody that's struggling to, stand up from the chair, for example, then I'll use a sit to stand. And I always think, as a physio, it's really important to do the simple things well. What I often see in practice is people who get to the end of the consultation and the time's been taken up with all sorts of different methods of treatment options, but the explanation of exercises takes up maybe 5% at the end. They're handed a physio tool sheet and they're on their way. So I think it's really important to do the simple thing very well. So we have to address, maybe for this particular patient, how do you sit to stand? Okay, so how many times can you do it comfortably? And quite often you'll find that a patient who expects that they can stand very comfortably from a chair with their hands across their chest can't do it. And that can be quite hard for the patient. They suddenly realise that they're not as good as they maybe thought they were. Or the opposite can be true. Some patients will find that they can stand 15 times comfortably from a dining chair. whereas they thought they maybe could only do 2 or 3.
Right, okay. And so there's really simple functional things that are, again, Socratic, they're goal-specific.
Yeah, and we get them to document this. I mean, I always say, okay, I'd like you to start sitting and standing or bridging or whatever it is. I want you to tell me when you're ready to stop, but I want you to have worked hard, ask your body some questions, get the security device starting to just get going, but not too loud. So to it, not through it, or cooked but not overdone, those sort of ideas. I make sure they've got that concept, and then I ask them to begin. And they stop when they're getting to that point where they've worked out hard, they've asked their body some questions. And then we ask them how they might start to develop. If, let's say, they could only do 12, how could they come back in 4 weeks and be able to do 25? Or whatever it is that's pertinent to them. And I get them to work out the answer to that question.
Okay, so you find them a baseline. Someone can do 10 sit-to-stands, where it stops them getting a sweat on and gritting their teeth, but equally it does challenge them.
Yeah.
So for the sake of it, say 10. You send them away doing a percentage level of that, do you?
Well, we'll maybe say, let's make sure the coast's clear. So if 10 was okay, what's wrong with starting at maybe 7 or 8? So let's pull it back down by 20 or 30%. Let's begin at a level that they're confident at, that their nervous system's comfortable at. And then, depending on how they respond over the next couple of days, so I'll normally write it down on a diary for them, on a calendar, and I'll say, okay, look, Saturday and Sunday you do this many. If then all's okay, then you build up and add 2 or 3 more in. You stay there for a few days. By Wednesday you should have been at this number. So we give them an idea, but this is a loose idea. I want them to sort of adapt that accordingly depending on how they've got on. And this, again, is promoting self-efficacy.
So their recognition of functional progress, not dissimilar to what Lee Harrington was saying in terms of the can run further, might still hurt, but surely that load increase is still progress.
Yeah, very much so, yeah. And I think it's really important for the patient and for their nervous system to see that there's some gain. And I always think one of the problems with graded exercise therapy is that often what we're seeing is the patients have got to be prepared and the clinicians have got to be prepared to put some work in initially without seeing huge results. This is a seesaw where the nervous system is really high on one side and sensitive, and the body is deconditioned and is low on the other side. Like any seesaw or set of scales, the body's got to start to develop and build a bit before the nervous system listens and recognises. So they have to be prepared for that. But one really good way that I think we should get patients to see that it's working, we always think seeing is believing, so show them that it works, is to use the patient's smartphone or get them to record the quality of their movement when they do a simple functional task, sit to stand, bridge, shoulder lift. How does it look? And they can then look back in a month's time and, like the dieter who can see that they've reduced by a dress size and their old pictures look much better or much worse, they can see where they've gone. And I always think if they can see it, their nervous system can see it. And
as far as filming strategies go, is that something that you took? I know you spent some time down in London understanding more intensive inpatient interventions that go on down there.
Yeah, with input at St Thomas's, and they do excellent work down there with their patients. And one of the key things that I got from the team down there was the use of video analysis and video function. And I think that's a really good, we all in practice sometimes get a little bogged down in our outcome measures, and lots of them can be paper and pencil exercises. If we look at actually what's pertinent to us and to them as patients, I mean, nothing more important than seeing it. Using a before and after shot on a video is a great way of showing them there's a change. And I think sometimes as well, we have to say to patients that, our best case scenario here is that we end up with a nervous system that's quieter and a body that's functionally better. That's the best case scenario. The worst case scenario is we end up with a body that's physically better and a nervous system that's still firing on all cylinders. So, what's more important, having a body that can do things with some pain, or continuing on the route that you're on at the moment?
And that brings us nicely on to really how you end some of your lectures, I know, is you've got to clarify someone's readiness for this. You present it as a package, you help them to understand what we can offer them, but sometimes it's not the right timing for the patient, or they're not in the right situation, either life-wise or body-wise.
No, it's always got to be the right time, the right physio, the right place, the right environment. Everything's got to be correct. And we can try as best as we can to try and get patients to understand how pain works and the complexities of neurobiology, and using collaborative metaphors to try and help them reconceptualize their problem. But the really important question is, are they ready? If they're not ready, then we're not going to head very far. I've had lots of patients before who exit the group that we have in persistent pain management, and they'll say, "I'm ready now. Where's the gym? Show me where to get started. I get it." And then I get other patients who say, "Well, I understand it. That's fine, but I'm all right with where I am. Thanks very much."
Okay, so understanding how to pitch it and who to aim for can stop us burning out as clinicians, making sure we pick the right patients.
Yeah, I think you've got to set the agenda, and the agenda has not got to be your agenda. It's got to be their agenda. And the only way to do that is to ask them, is this important to you at this current moment in time? Is this something that you want to take on? If so, this is what it's going to involve.
So patient education comes down to sometimes good sales techniques, and selling a package of honest care that is based on the best research. But any good salesman can walk away without it breaking his heart, and sometimes a patient might not want what we're selling, and despite best understanding, they're not ready for it. We need to be able to accept that and not be hurt by it.
Very much so. And again, we come back to this idea of relativism and commitment in terms of stages of learning development. And for those clinicians that have reached that point, I think we should be happy with the patient and the patient's choice, because this is all about choice. If the patient wishes to go off and have a repeated intervention that they've tried many times before that hasn't worked, I think it's our duty and responsibility to point out the disparity there. But equally, I can't necessarily change everybody's thinking here. It's about learning where our limitations are, but doing the right thing by the patient for the long term.
Do we sometimes lose sight of what patients actually want?
I think, yes, we can all be guilty of that. I think, time constraints and within practice can often lead us down a path that we want to choose rather than what the patient really wants. In my presentation that I give to clinicians and to patients as well, I use some work that was done by Yelland in 2011 over in Australia. And he asked the question, what is it that patients want with persistent pain? And the big things that came out of that were really a positive shift in attitude, a change of perspective, a change of perception, you might argue, and also being believed to and listened to, a social legitimization. So, and if I think, what underpins some of the most extreme positive reactions that I've seen in practice over the years, it's not all of those technical skills that I learned as a student. It's the fact that the patient felt that I believed them. I believed that they could make a difference and they could change, and I think that's a big part of this. The other thing that they also wanted was acquired knowledge. They wanted us to try and teach them about what this is, as well as pain relief. And I think a top tip, I suppose, to use in practice is sometimes ask a patient, or especially with a group of patients, to write down a list of wishes. So we have a wish list. When we go on a course, we sometimes think of, the presenter will say, what are your wishes from this course? What do you want to get from it? What are the aims? So you can, again, pick up and highlight any mismatch. For example, if a patient comes in, or a group of patients come in and they say, well, I want to get rid of my pain, that opens an avenue for discussion there as to why we can't do that and what we should be aiming for. If the patient comes in and says, well, I'd like to be able to become better at picking up the kids from school, but I'm aware that I'm going to have some pain continuing, then we can discuss that too. And I think if we look at some of the work that was done by Eccleston and Cromberts in 2007, and they used a very sensible model for persistent pain, which looks at a perseverance loop of patients who head round a biomedical problem frame where they start to worry. It makes them catastrophize, as we've already discussed, and seek help. They then seek the off switch. That can fall in line with the medicine as a battlefield and the escalation. They then seek this problem-solving behaviour and find the temporary relief, the mosquito bite that gets scratched, that feels nice for a while, the endorphins have kicked in, and then it comes back again, it's unsolved, and they're back around the same loop. So when I show this to patients, they recognise this loop. Some of them have spent a fortune going around that loop. So our job is to try and get them to understand the problem and to learn how to manage it for the future. So they have to reframe to exit that loop.
And we can definitely make these diagrams available to the listeners as part of the show notes newsletter that goes out. So that'll be a really useful resource. Okay then, Mike, I've got a few awkward questions in and around this topic. The patients that have got many complex psychosocial issues, examples being that they're out of work, they're struggling with their home life and it's affecting their relationships, or even they've got really complex issues that are stopping them doing the sport that might even be their profession to some point. How are you addressing those issues best?
I think we have to be aware as a physiotherapist, although we work almost in a hybrid form, incorporating psychology and sociology into our practice, we have to be aware of where those boundaries exist. And I think in practice we always have to be aware of where we need to, if there are very complex issues that are affecting patients in terms of maybe agoraphobia and social withdrawal, for example, I can do my best to see if I can help. And I can use some of the skills that I've adapted over the years, as we all do in practice. But I think we also need to acknowledge where our boundaries lie and have good referral sources onwards to appropriate clinicians.
And what would we say to the patient that says, well, this is all well and good, but what do I say to my boss or my husband or my friends, my sports coach?
Yeah, I had this a while ago. I recall a patient who I had managed quite successfully and she was doing very well. And she said, this is great, I understand all of this, but how do I explain this to my boss? And it really made me think. Again, I like patients that make me think. I think that's a challenge. And I again, using Einstein to try and back me up, as I think is always a good idea. Einstein once said, you do not really understand something unless you can explain it to your grandmother. What does that mean? Okay. And I sort of think that the learner, the patient, has to become the teacher. And if we come back to Hebb's rule, nerves that fire together, wire together, we all know as learners, the more we repeat something and contextualize it in our own mind, the better we understand whatever that concept is.
Encouraging people to then go on to teach it and explain it in their own way.
Very much so. The message has got to be reverberated by the people who've learnt it.
Does it get watered down though? Could it be Chinese whispers in terms of this message?
That's one of the risks. It's definitely one of the risks, yeah. And I don't think there's any sort of way that we can prevent that from happening. I think that's always the way that interaction between humans works. I think this is why it's really important, and a classic example of this is the internet. The internet has lots of wonderful things, and I'll make note hopefully at some point as to where to look for good things. But there's also, as we're all aware, lots of damaging, harmful things. There are words that heal and there are words that harm. There are internet sites that heal, there are internet sites that harm. So,
of course, yeah. Education's right power, direction. But also, not always a good thing. Yeah. And so if I make some bold, sweeping statements over what we've talked about today, good quality education leading to rehabilitation of a physical sense, of a physical being, with some mindfulness strategies and education that's not always just exercise-based. But where do other interventions come into your work? Because I know that from working with you in the past, that's not all you do.
No, I think sometimes there's this assumption that because I practice a biopsychosocial model, that it's a psychosocial model. I've had it before where clinicians will say, oh, so you just talk to them, you talk them better. And you think, well, no, that's missing the point, really. I always, again, metaphorically consider the idea of pain as a complex problem. And if you look at trying to make a complex recipe for a gatto, you don't get there by throwing flour in the bowl. If you're using acupuncture as your single mode of intervention, and that's 98% of your recipe, you're just going to end up with 98% flour. You need to have a good combination. So passive modalities are effective when used with a good understanding of their limitations, and that has to be a collaborative understanding. That discussion's got to take place between the clinician and the patient prior to embarking on a road of passive modality.
You've mentioned a dislike for the whole hands-off, hands-on debate. It's somewhere well in between that you feel you live and everyone should live. But what's your thoughts on how they can be best utilised?
I think it depends on the individual. Again, it's unique to the patient. So some patients will, let's say some patients will have benefited from manual therapy in the past. That's great, that's fine. Again, a bit like the mosquito bite that's been made to feel quite pleasant when you itch it. The question then to ask the patient is whether it was sustained. Did it have a positive consequential effect where it enabled them to then start, as Lee Harrington has pointed out, to start training successfully? If it has, then do we use it again to kickstart the engine to get things running? Again, it comes back to that question of, is it adaptive or maladaptive? If it's adaptive, use it. If it's maladaptive, be aware of its downfalls and its limitations.
And explain what it's actually doing to the person. Don't glamatise it at all.
Very much so. I mean, I think that quite often with any passive treatment, always be aware of its limitations physiologically and neurophysiologically, but also at the same time be aware of the impact that it can have on you as a clinician. You can begin to perceive that what you do is magic almost. I mean, I sometimes look at some of the modalities that are used in passive management, and it almost seems a little bit like a magic trick. And I remember doing some of these things with patients in years gone by and feeling that my hands were, like magic wands. And the reality of that is that's not the case, really. We know that's not the case. So we have to be honest and very truthful with how long-term persistent pain works, and also acute pain.
Of course, yeah, and the influence of how that will affect their future management of other conditions.
Yeah, very much so.
Okay, and so of the more passive modalities, we're in agreement that there's a place for them, but where does medication sit within that? Because it's often useful for getting people going. What are your top tips on getting people to utilise medication properly or well?
Well, I think, again, it comes back to the point we made earlier, that if you can draw a comparison between how people manage all sorts of different conditions, for example, diabetes. If you've got a diabetic patient who's not taking their metformin or their insulin, then you're in for trouble. That's then a condition which is a very unpredictable roller coaster ride. It's moving all over the place. Of course, if they take it regularly, not dependent on their symptoms, but dependent on the time that they take it as stated on the box, then they manage things much, much better. So again, I ask patients that question: how would you manage diabetes? What do you think your symptoms might be if you forget to take your medications for a week?
And they don't get addicted to the insulin, but yet they consider paracetamol a more addictive substance.
Yeah. I think also one of the things to try and get across to patients is the fact that one of the biggest indicators of poor outcome in physiotherapy, particularly, or physical rehabilitation, is inadequate pain control, particularly at the start of the process. If I'm trying to get a volcano to simmer that's very bubbly and hot without a lid, then I'm not going to get very far. I've got to try and get the sensitivity level down to enable a starting point. But again, I mean, we shouldn't labour on the point if the patient's belief is that they shouldn't be taking pain control, that they don't want to take pain control, that they're concerned about the negative side effects, then that's their decision.
But it will take longer, and you need to make sure you adjust their understanding.
They have to be aware of that, yeah. It doesn't mean that we can't help, it just makes the job a bit more tricky at times.
Okay, no, good. And so, in terms of then a more biomechanical model in which we would work, or could work, does it go too far the other way? Could we see techniques such as exhaustative kinetic control, motor control, Pilates interventions, the fascial system coming to the fore? All of these things are more biomechanical in their ethos. Is that helpful or unhelpful, do you feel?
I think they're helpful if seen within a contextual pattern, if seen within a broader picture. Again, come back to the idea of the Mona Lisa and being able to step back and see the bigger picture within that human being. I think where sometimes the problem with our reasoning as professionals is that we do categorize things, and we can all be guilty of heading down a road of looking at one intervention. I mean, who of us hasn't been on a course particularly that hasn't led to every single patient having those symptoms that necessitate that particular treatment method? Mm-hmm. We all do that. That's part of our learning process.
Yeah, we immerse ourselves in the latest thing we've learnt about to try and sell it to ourselves, justify it to ourselves.
Yeah, but I think most of us come to the conclusion that we take bits and elements of all different paradigms and we merge them into something that hopefully works for us, because otherwise we're going to burn out if we don't do this, and also most importantly something that works for the patient.
Useful parts of a recipe.
Yeah, at a level that makes sense to them.
Lovely.
Not to us.
Okay, no, that's good. And another tricky question for you, Mike. When to stop?
Well, yeah, I think this is always a difficult question, really, and I think we can all be guilty, me included, of trying to help everybody, and I think we always have to acknowledge and reflect that we can't help everybody. The methods, the biopsychosocial methods that I advocate, don't work for everybody. So I think from a CBT perspective, from cognitive behavioural therapy, we always look for, is the person ready, as we've discussed? Are they accepting of the fact that they have a problem? And are they ready to then start doing things? And if those questions are answered with a positive, then we begin. If we're not seeing a great deal of change within a month, 2 months, 3 months, if there's resistance to change, if there's no sign of a degree of psychological and physical flexibility, then I think that awkward conversation needs to be had. Where are we heading here? And if you as a clinician and them as a patient don't feel that we're seeing a great deal of result, we have to then question, is it worthwhile?
Okay. Yeah, no, that makes sense. And as well, that brings up a point that although a lot of this is most useful to some degree with chronic pain patients or complex patients with multiple different pain perception issues, this is education that can be applied in a fundamental level when someone sprains their ankle for the first time.
Yeah, this shouldn't be seen as, and I think this is a mistake that's commonly made, really, which the perception is that this is only for human beings that have had pain for more than several months, and this isn't. This is for everybody. This should be for people who have got acute pain, or it should also be for family members of people who've had pain for 2 days or 3 months. If I think about some patients that I see who have acute whiplash injuries or acute ankle sprains, I use the same model, and it works. It comes back to Vlain and Linton's model of fear avoidance. What we're really after is for them to head out in the positive route of confrontation of the problem, and then acceptance of the problem and moving forward and recovery.
Fantastic. No, that's great. And in summary of this then, if all the research is pointing us in this direction, and there's people like yourself, David Butler, Lorimer Moseley, Louis Gifford, been talking about this for a long time, there's increasing voices in this area, why is it not at the forefront of all clinical practice in the UK and in the world?
I think you've stumbled into the million-dollar question there, and I think this is a question that I hear asked by lots of patients who often complete the course that we run, often come back to their GPs and their doctors and say, well, I seem to have a better grasp on this than you do. So I think the answer to that question is it's a challenge. It really is. And I think if our traditional biomedical teaching has led our thinking down certain paths, we have to use that knowledge, but also be aware of the limitations of that and start to think about what other avenues should we be exploring here, which is, I think, any reflective practitioner must do that in their thinking. And if I think about why isn't this being used more in practice, I suspect, and others suspect, that it's the challenge that's the difficult thing. This is, you've given me here an hour and a half or so to talk about something that's a very broad and complex issue. And that's the difficult thing in practice, is having those skills to try and communicate this broad and complex issue to patients who are frustrated, angry, upset. It's the hard job. It's a really challenging job to do.
So it's easy to fall back into our comfort zone.
Yeah, very much so. And I think sometimes, I think back to years gone by, and I pray for that day where I could sit and talk to patients at a nice, comfortable level about their holidays and where they've been and what they've done, and not challenge their beliefs, and ask them to lie prone and do some passive intervention. It would be very pleasant, but that's not the reality of practice. In my eyes and in many other people's eyes, and I think there is a change. I know within the chiropractic and osteopathic worlds, this change is taking place from within, and I think that there is a danger here of we have to adapt or perish, as Darwin once said. We do need to move forward a little with our thinking, but it would be impossible to say that this isn't a challenge. This won't take us out of our comfort zone.
So, Mike, you've worked in a number of different areas, such as, although it's all mainly MSK based, but you have done locum work, I know, historically in other areas, but also in the private sector. You worked in sport with athletes. And how does that differ? How does that influence social context?
I think the first thing to say is, whether you're paying money to see a clinician or not, you're still a human being. You still have those same issues. I think sometimes there's a misperception here that there's a big difference between people who we see privately and people who we see in a public setting. I think they're all the same at the end of the day. We still have these issues socially, physically, psychologically, cognitively, that require our sometimes provocation of disparities and mismatches that we should approach. I think the biopsychosocial model doesn't necessarily sit comfortably all the time with a private practice model. I had it once said to me, how am I going to pay my bills if I teach my patients how to do it all themselves? If we're trying to promote self-efficacy, then how as a business model can I have people coming back in to see me? The interesting thing that I've heard from several very successful private practitioners is that they moved away from doing what was expected of them, doing short-term interventions to help the patient for a while, because of the fact that they didn't feel they were getting very far, and patients were starting to get a little upset about the amount of money and time and effort that it was taking for them to try and recover, that they weren't really recovering, they were having short-term help. So they moved in towards this model of being honest and upfront about what we can do for pain, and what the patient has to learn to do for pain. And actually, they found that their business model became much more successful, and I suppose that comes into word of mouth. All business is word of mouth, and we know patients are very knowledgeable about whether something's working and helping them in the long term, and how much money is pouring out of their bank account if it's not.
Of course, yeah. And how do we help get away from such a defensive nature that the profession or the industry seems to have, and our arguments about different systems and different ideas? How do we sort of distance ourselves from that, or are me and you being just as provocative as the rest of them today?
Well, I think it is a discussion that is being had, and I think it's getting louder as the months and years are going by, which is good. It needs to be had, this discussion. But I don't think we should see it as a dualistic conversation that exists between two very different camps in their trenches. I think this is a conversation that should be trying to help patients at the centre of it all. And I think we have to use the evidence, and we have to use our clinical reasoning and our beliefs to come together and decide on the best route for patients.
Using this model in a sports field, okay, with a lot of sports physiotherapists that listen to the podcast would argue that their hands are even more tied. What would you say to that? How could these interventions be best applied in a sports context?
Well, I think there's a sense within sport that there has to be a biomedical element here. There has to be a mechanical component, because that's the very nature of the job. But also, I mean, we can't divide the psychology of the sportsman. I think if we think about sports psychology, plays a huge role in sport these days, and it's acknowledged as being a very useful component of an athlete's rehabilitation. But we can't merely look at sports psychology from a performance perspective. We also have to think, well, is there an underlying problem here in terms of how this athlete thinks that's stopping them from being able to develop physically? And for us as physiotherapists, within sport, yes, we might be addressing the biomechanics, but we can also almost surreptitiously start to consider some of the more psychological and social components that come along with pain. And remember that athletes are no different from any other human being.
Mm-hmm. Yeah.
Well, maybe they are. Maybe actually they can be more of a challenge because they're more high achievers.
Yeah.
So in one regard, we have to consider that within how we manage them.
Of course, yeah. And I think that's a really fair point, to consider that they might have different challenges and they might need to be approached in slightly different ways, different interventions, but fundamentally we still need to work out what makes them tick.
Yeah, I think so. I think that's a very good point.
Lovely, Mike. So where would you direct people in terms of if they want to understand more about this topic, which obviously we've only just scratched the surface of?
Yeah, there's a lot of work out there, a lot of very good work out there, and I often think that it's very hard to try and get across the message of pain perception to patients on your own. So why not use all of the great work that's already been done for you to try and prove your point almost, and show them that it's a worldwide topic.
Show them that it's not just your idea.
Yeah. And I often, almost as a placebo in one regard, I often use a lot of the work that comes out of Oxford University. As soon as we say Oxford University to most patients, their ears prick up. So very important. So I think in this day and age, when we're looking at multimedia tools of learning for patients, I split it into watching. YouTube has got many good videos. Understanding pain, what to do about it in less than 5 minutes is an excellent 5-minute video that I often show to patients, as is Lorimer Moseley's work, Pain, Is It All Just in Your Mind? Understanding human pain, suffering and relief through brain imaging is something that was done through Oxford University. Peter O'Sullivan's work, anything that he does on YouTube is really useful to look at graded function.
And all of these lectures and videos are all available for our listeners. We can send links to those, I assume, yeah?
Yeah, definitely. There's also, I think, with regards to listening, besides listening to these podcasts, thegreatcourses.com has a lot of audiobooks by Professor Robert Sapolsky, which are very useful to listen to. ableradio.com has fortnightly podcasts run by Pain Concern, which covers a lot of topics related to pain. And from a reading angle, I suppose the classics, Explain Pain by Butler and Mosley, and Painful Yards by Mosley, and Why Zebras Don't Get Ulcers. And also Linton's book I would recommend to any clinician, which is from 2005, Understanding Pain for Better Clinical Practice, a psychological perspective. I think also one of the key people who's had an impact on my career over the years has been Louis Gifford. And I think Louis Gifford's work in the vulnerable organism model, and particularly looking at achesandpains.com, is a really, really useful resource for both patients and clinicians.
I can definitely agree with that. I can't recommend that highly enough.
So there's a lot of very useful and comprehensive work out there. Just knowing where to look is half the battle sometimes.
Okay, that's your external plugs then, Mike. So here's your chance to tell us a little bit about how people can get more information from or more of you.
Yeah, I suppose there's a few ways really. I mean, I run an evening lecture, and also for second opinions clinically, I'm available through Choose Health. So you can also access me through there. And I've got a couple of speeches coming up at the chiropractic conference next year. That's available to chiropractors and also any other professional. And quite interestingly, their conference this year or next year is based on communication in practice.
You'll be in amongst the lions then, will you, Mike?
Yeah, but in a good way, I think. I think it's useful. There should be more interprofessional interaction, and sometimes, again, we do come back to our very dualistic regressions of our trench warfare that we have, and if we're trying to help patients, let's all get together and discuss how to help them best.
So thanks a lot for your time, Mike. Really appreciate it. I'm sure we will have opened a few cans of worms, and we might be called to answer to it one day, so we might drag you on for another podcast. But till next time, thanks a lot.
My pleasure. Thanks very much for having me, Jack. I think it's important to try and get this message across broadly. It's building volume, but it's still very quiet.
Well, one thing's for sure, Mike, we can certainly be noisy. And that was session 5. Many thanks to Mike Stewart, who, like our previous podcast guests, Dr. Lee Harrington and Dr. Ian Horsley, supported the podcast in its infancy. As I record this, the podcast is approaching 15,000 full listens, despite us only launching 4 months ago. A huge thanks to those spreading the word, and please get in touch with any feedback, reviews, suggestions, or even abuse. The podcast team tweet from @TPM Podcast. I'm @choose_health, and today's interviewee is @NoPainMike. You can also rate and review us on iTunes or email physiomatters@choosehealth.co.uk. As per usual, we will be sending out a podcast show notes newsletter to our subscribers later this week, so sign up at choosehealth.co.uk for links to the podcast timeline, relevant full-text articles, and Mike's latest piece written for pained.com. This summer, Mike is taking his award-winning course on the road, with 2-day courses planned throughout the UK. And following the positive reception of the podcast, we've decided on a Choose Health No Pain collaboration, which is organised for Manchester on the 26th, 27th and 28th of July. All course details are available at nopain.co.uk, where you can sign up and book your seat. The 2-day No Pain course leads to an optional 3rd day in which we explore how to integrate movement, exercise and passive therapies into rehabilitation, regardless of whether you work in the public, private or sporting sectors. As a special offer to podcast listeners, the additional 3rd day is priced at £75. However, spaces will be limited due to the workshop-style format of the day. We hope to see some of you there, but in the meantime, I'll leave you with Mike for his cheesy sign-out, as it was rather popular last time. It's bye from me for now.
You've been listening to the Physio Matters podcast, discussing physio matters because physio matters. Any more cheese and I'd be fondue.